Okay. Hey guys, we're doing chapter 10 today. It's medical. There is a ton on here. I'm not going to read every slide. I'm going to do a lot of rambling, so just bear with me. So, we're going to recognize and manage life threats based on our assessment. Okay. Which we talked about chapter 9. Assessment's huge. From here on out, you're going to hear that a lot. We're going to talk about the abdominal and gastrointestinal disorders, endocrine disorders, cardiovascular, respiratory, so we're going to upper and lower alveoli. Some common medical conditions that we are going to hit, and we're going to break these down one by one with their meanings and examples. Real quick, I'm going to run over these. So you've got angina pectoris. That's chest pain or discomfort that occurs when the heart does not receive enough oxygen-rich blood. You've got heart attack. That's going to occur when blood flow to the heart is suddenly blocked, which once again is going to take away that oxygenated blood. We've got congestive heart failure, or CHF. This is when the heart cannot pump effectively, and so we begin to build up fluid in our tissues and organs. Dyspnea, I can't say it right now. Uncomfortable or short of breath, dyspnea there. Asthma, which is inflammation or tightening of the airways. Stroke, it's when brain cells die due to a lack of oxygen-rich blood. Hypoglycemia is a condition that occurs when the blood sugar level drops too low. Diabetic coma, a life-threatening disorder that can happen when blood sugar is very high or very low. And then abdominal pain. Different things can cause abdominal pain. We're going to talk about some of the major ones. Once again, we're going to treat our patients based off of our assessment and what we find. So let's jump in. We've already talked about assessment. So our scene size up. This begins as soon as we receive a call or we see an incident. Make sure the scene's safe. We make sure we have our PPE on. We've called 911. Do we have everything we need? Primary assessment. Okay, we're gonna this is where we're checking our ABCs, so our airway, our breathing, our circulation. We're treating life-threatening situations right now. This is when we treat life threats. And then we're going to get some history using that sample or OPQRST that we've talked about. Once again, I have separate videos on my YouTube channel that talks nothing about or talks only about history taking, or only about scene size up, only about primary assessment. So we can break those down and learn them in sections instead of just trying to do it all at once. You then move on to your secondary assessment. This is where we're going to treat secondary injuries or non-life-threatening stuff. And then our reassessment. Once we finish assessing, we reassess. So we have our starting point and we work through our assessment, and then we do another assessment and we see if anything's changed. And then we continue this until one, higher level of care arrives, or two, we arrive at the emergency room. Let's see. Patient assessment. So it's going to talk a little bit more about that. Review dispatch information. So whatever dispatch sends us, we need to review it. We need to talk about it with our partner. We need to understand what we're walking into. Carefully assess scene to identify safety issues. So once again, my safety, my partner's safety, then my patient safety. As you perform primary assessment, try to form an impression of problem first. This is that one I gave a sample of during our assessment chapter. I roll up or I walk up on a man laying on the driveway, whether he's responsive or unresponsive. I'm looking, I'm studying my scene. There's a ladder knocked over and about half of his Christmas lights are hanging. Immediately, he was up on the ladder. I want to take a rough guesstimate at how high the roof was. Okay, he was 12 foot up. Ladder slipped out from under him. He fell onto a concrete slab. So I just did my general impression. I just got an idea of what could be going on. And that tells me immediately I need to start looking at a traumatic event. or I walk in a house and someone's in a tripod position leaning forward and I can hear them breathing from across the room, I immediately know, okay, I've got a respiratory event. So it's just kind of a visual, use some common sense and build a picture in your brain somewhere to start. And then we're going to determine the patient's responsiveness. So we're going to walk up there, we're going to introduce ourselves, we're going to check those ABCs. So when we walk up there, remember, we don't hover above people. We get down at their level. We talk to them eye to eye. If they're able to communicate with us, that's awesome. If not, then we're going to work through our assessment and find the problem. Remember, we're using that AFPU, and we'll talk about it here in a minute, but if they're alert and they're making sense, they can tell us what's wrong with them. That's the chief complaint. If they are not alert or they're making no sense, they're super confused, it's our job to find the chief complaint. It's our job to find the problem by using our assessment and the tools we have handy. So usually it's best to obtain your medical history before we do that secondary assessment. So secondary is when we're going to be doing they're not dying from it, but we're going to put a Band-Aid on it type of deal. So if we can get history, we like to use the sample mnemonic. So sample is, see if I can get my pointer here. S, signs and symptoms, allergies, medication, past pertinent history, last oral intake, an event leading up to. Write those down on a piece of paper, write sample down the side, and then write what each one means. And then besides that, write in your own words what it means. So I would write my S, I would put sample, or sorry, S, I'd put signs and symptoms / something I'm seen or told. A equals allergies / things that people are allergic to. And I will do that on a piece of paper over and over and over until I just know it. Because when your test comes, your skills test, it's really good to be able to just kind of fly through that. Or when you're working on a patient, you're not going to sit there and be like SAMP. You're going to just kind of know what you need to ask. You get in your own rhythm. Everybody's a little different, but we all go after the same basic information. So obtain patient's vital signs. So vitals, we discussed how important those are. Those are a benchmark. That's where we start. Those vital signs can tell us a ton. The longer you're in class and the more we practice, the more this will be obvious to you. So we want a blood pressure. We want a pulse, quality and rate. We want respiratory rate and quality. We want a temperature. We want a blood sugar on every patient. Trying to think here. We want pulse ox. What's their oxygen saturation? Another one, the AVPU, alert, verbal, painful, or unresponsive. What response are they? What level are they when we meet them? And then when we're pulling up to the hospital or when EMS is arriving on scene, hopefully you're talking to your patient and there should not be a deviation in that. They should be alert. They should be able to talk to us, or they started out that way and now we're seeing that they're confused. That's super important. So we always need to check all vital signs every time we do an assessment. Monitor the patient through reassessments. We've talked how important that is. Always reassess. Remember to reassure your patient. We're not going to lie to patients, but we need them to know that they can trust us, that we know what we're doing, that we're professionals. General medical conditions, they're all caused by something different. Sorry, I'm reading my notes here. So as an EMR, your initial treatment can actually stabilize, if you will, or maintain where that patient's at until higher level of care arrives or we arrive at the hospital. I said a couple chapters ago, from the second you meet them, we want that care to move forward. We never want it to move backwards. So when you arrive, We are going to introduce ourselves. We're going to decide if they're alert. We're going to get our vitals. We're going to get that history. We're treating any life threat. And we continue to move forward from there. Something as simple as calming someone down having a panic attack can actually save their life. As crazy as that sounds, panic attacks can be deadly. Altered mental status. So a sudden or gradual decrease in the patient's level of responsiveness. Use AVPU, alert, verbal, painful, unresponsive. If you haven't understood what that means up to this point, because I know I've said a lot, A is awake or alert. An alert patient will answer simple questions accurately and appropriately. They can, who they are, if there's a picture of their grandson sitting on the table beside them, ask them who that is. They should be able to know where are they. They should be able to tell you what town you're in at least. What day it is. This can be a little bit of a tricky thing, like with nursing home patients and stuff. Sometimes they're confused on what day. One of my favorites is how many quarters are in a dollar. So that's alert. If I walk up and I can ask them a question and they can answer me correctly, they're alert. Verbal, I walk up and I talk to them and I don't get anything and I have to raise my voice, or I have to almost yell to get a response. That's a verbal response. If I walk up, they don't answer my questions. I yell, they don't answer me when I yell, but I can sternum rub, or pinch the back of their arm or pressure point behind their ear, and I get a response from them then. That's a painful response. It might only be a moan, but that's a painful response. And then you've got unresponsive. I do all of the above and nothing happens. They are unresponsive. When assessing a patient's mental status, consider two factors: the patient's initial level of consciousness, any changes in the level of consciousness. So I can take that a little bit further. What's their normal? If there is someone on scene that knows them, turn and look at them and say, what's normal for this patient? Do they usually talk? Do they usually communicate? Are they usually pretty with it? You can ask those questions. So just keep that in mind. And if you get any changes, then we know something's going on. You need to communicate that back to dispatch so they can tell us, because we're in route. Conditions causing this altered mental status. We've got head injury, shock, decreased level of oxygen to the brain, stroke, slow heart rate, and high fever. We also have infection, poisoning, low levels of blood glucose, insulin reaction, and psychiatric conditions. So head injuries, that's a big one. Shock, we're going to talk about. We've talked about decreased oxygen. Stroke, we're going to talk about. Slow heart rate, you're not getting enough oxygen or oxygenated blood to the brain. So it's going to cause that. High fevers, we're going to talk a little bit about that in children and infants. Febrile fever and what it can cause. Infection, poisoning. Anyway, the big one I really, really want to point out right now would be the low levels of blood, because this is why it is so important for us to go and get that blood sugar when we do our vitals, because a lot of times the tracker can mimic multiple things. So we roll it out right there towards the beginning when we do our vitals. Initial treatment: maintain patient's ABCs and normal blood or body temperature. So what we're doing there is we're going to keep an airway open. If it's not, we open it. We're going to make sure they're breathing adequately. Sorry. If they're not, we're going to breathe for them. And let's make sure their circulation's good. Okay. We need be, yeah, we can start CPR when their pulse stops and all that. But okay. Part of this is treating for shock, so that maintaining that normal body temperature. A lot of conditions will make people go into shock, so we just want to make sure that we are not losing body heat. Keep patient from additional harm. If the patient's unconscious and has sustained trauma, place patient in the recovery position, or has not sustained trauma, put them in the recovery position. or use an airway adjunct. So the big thing, like I've briefed for, is ABCs. Be prepared to suction. So we got to keep that airway open. If it's not open, we open it for them. Caused by sudden episodes, seizures. Sorry, we're on seizures now. It's caused by sudden episodes of uncontrolled electrical impulses in the brain. Generalized seizure. It produces shaking movements, involves the entire body. It lasts 1 to 2 minutes, usually leaves patients unconscious. If you are on scene and someone has a seizure, it's really hard to do this. Remember to try to time it. Even a rough estimate goes a long ways. Generalized seizures caused by a sudden high fever. These are called febrile seizures. They occur in infants and children the most. They can be deadly. Absence seizures result in only a brief lapse of consciousness. Patients may blink, stare, or jerk one part of their body. The ones that I have personally seen, they are just not there. They will literally, they don't fall down. I mean, this person just stood there and there was nothing. He drooled. He didn't blink. He didn't move, and it lasted about 15 seconds. And then all of a sudden, he's back to normal, like nothing ever happened. So it's just something to keep an eye on. If you run on someone with a seizure, even if they pop out of it and they're like, "Oh no, I'm good, man," let's go ahead and convince them that they need to go see a doctor, even if they go in a private vehicle or family takes them. Because these can be leading up to something more serious. So we want to monitor the patient's ABCs and arrange for transport. Seizures can be caused by epilepsy, trauma, head injury, stroke, shock, decreased level of oxygen to the brain, high fever, infection, poisoning, overdose of drugs or alcohol, or both, brain trauma, brain tumor or infection, diabetic emergencies, complications of pregnancy, or unknown causes. So that's a big one down there, that unknown causes. There's not always a cause that we can find or we know. So we treat our patients based off of our assessment. We treat our patients based off of our vitals, and then we move on. So treatment, usually seizures will be over by the time you arrive on scene. If it has not ended, focus on protecting the patient from injury. Once seizures stop, ensure an open airway and place patient in a recovery position. So we never ever want to hold a patient down or try to hold them from seizing. We don't want to do that. Let me see what this next thing is. Treatment. Okay, if patient does not resume breathing, begin mouth to mask, administer supplemental oxygen. Okay, I want to make sure I wasn't jumping ahead. So you get a patient who is seizing. We want to protect them from hitting objects that are around them, protect that head, move chairs out of the way, move tables out of the way. Don't necessarily move the patient. That's their body's response. It needs to be able to do it. If you try to stop it, it's actually going to do more damage internally. With that being said, I personally have had seizures before, and I can tell you that the person seizing can hear and understand a lot of the time. So it's important that you stay with the patient. You, once again, like I keep saying, you verbalize everything you're doing. Talk to that patient. Tell them you know they're scared. Tell them you understand. Stay there with them. Stay calm. The calmer you are, the calmer they'll be. Explain to them. Don't fight it. Don't fight it. Just let it happen. It'll be over in a minute. We're right here with you. If it's a super bad seizure and they're foaming out the mouth, we're going to have to let them seize, and then we need to turn them on that side and get all that out. We might have to suction them. The most important thing I can tell you from a personal standpoint that your book's not going to tell you is be compassionate. Talk to them, stay with them, let them know that someone is there who cares. That goes a long ways in them staying calm. Special medical conditions. So you will find it helpful to be knowledgeable about some of the specific medical conditions that you might come across. This information will help you assess, treat, and communicate. Guys, I've said it in other chapters. If you put the work in, this class is like 3 months. put the work in, study it, look stuff up, read your chapters. It's better to know your stuff for treating a patient than it is to memorize your stuff for passing a test. I don't think anybody takes this class just to pass a test. You take it because you want to help people, so it's worth the time to study it and know it. Don't memorize it, learn it. There's a difference. Heart conditions. The heart must receive like constant oxygen, or it will die. Heart receives its oxygen through a complex system of coronary arteries. These arteries may narrow as a result of, I can't ever pronounce this word right, atherosclerosis. I told you in the beginning I couldn't read very well. So what it is it's when the fatty tissue or plaque builds up in the arteries itself. So if you will, sorry, my camera's up there. So your artery is yay big and it builds up. And so it's actually, with the buildup, it's only this big. You're only getting a quarter of what your heart needs as far as blood flow. It's going to affect it. So it builds up junk on the inside and we get less flow. Sorry, there's a fly in here. So it can cause that angina pectoris, like we talked about. It can cause a heart attack. It can cause cardiac arrest. We're going to talk about all those. Chest pain. So angina pectoris is chest pain caused by inadequate flow of blood and oxygen to the heart muscle. So exactly what we talked about. We took our normal sized artery, it's built up a bunch of junk inside it, so it's actually a lot smaller now. We're not getting the same amount of flow. So a portion of our heart is essentially dying. Often described as pressure or heavy discomfort. Patient is often short of breath and sweating, is extremely frightened, and has a sense of doom. Often brought on by exertion, emotion, or eating. I think there's a picture somewhere. We'll get to it. So these people were going to show up. They're going to be struggling to breathe. They're going to be scared to death, and they will be repeating the phrase, I'm going to die, I'm going to die, or am I going to die? They feel like they're going to. They're going to be cold to the touch. They're going to be covered in sweat in places you didn't know they could sweat. Sometimes they're going to be nauseous. There will be vomiting, extreme chest pain, crushing pain. Let's see. If the patient is already being treated for a heart condition, ask them if they take nitroglycerin. Have you been prescribed nitroglycerin? If they have, you can help administer one nitro under the tongue or give the nitro spray. If the pain has not got better in 5 minutes, we can give another dose. If the pain has not got better after that, we can give one more dose. Always follow your local protocol. If you're allowed to assist with nitro as an EMR, awesome. If not, maybe that patient can do it on their own with you standing back and maybe giving guidance. Or you can, once again, be on the phone with 911, or if you know your EMTs that are on that day, call one of them and say, hey, this is what I'm doing, this is what I got. It helps us a long way. So something that we need to look at when we're talking about nitro is if you're going to give nitro, you need to make sure that systolic blood pressure, that top number, is above 100. What nitro does is it goes in there and it causes them arteries to open. So when you open those arteries, our blood pressure, if you'll remember that blood pressure is the amount of pressure on the artery. So if them arteries are opened more, the blood pressure goes down. So if we already have a low blood pressure and we pop nitro in someone, we can tank them, we can bottom them out. So we need that blood pressure to be above 100. That's systolic. Okay. Check your protocols. Your protocols might be different. That's just an easy number to remember. So the result when one or more coronary arteries is completely blocked, And the two primary causes of coronary artery block is severe arthros, yeah, that word again, or blood clots. And I apologize, I cannot pronounce that word. Get used to it because there's a lot of words I can't pronounce. So right here we have a coronary artery blockage, which actually is right here. That's that coronary artery coming down that's feeding the heart. You notice that this area here is a different color. This is a purplish blackish color. That's because that area is starving. It's not getting oxygen, and that part of the muscle is dying. And once that muscle dies, it cannot come back. Myocardial infarction, it results when one or more of the arteries is completely blocked. So myocardial infarction. Signs of a heart attack include the patient suffers immediate and severe pain. It's going to begin probably in the chest or in the back. The pain may radiate from the chest to the left arm or jaw or to the back. Some, mainly females, it will be in the abdomen. They'll have pain. Patient is usually short of breath, weak, sweating, and nauseated, and may vomit. If blocked area is critical or large, heart may stop completely, which now we're doing CPR, right? Complete cessation. Oh, sorry. Complete stopping of the heart is called a cardiac arrest. When the heart stops, we're in cardiac arrest. Cardiopulmonary resuscitation, or CPR, is your first emergency treatment. Take the following action. So by the time we're doing this chapter, you should have done CPR in class already. So we're going to follow that chain of command. We're going to recognize a problem. We're going to call for help. We're going to get an AED in on its way. We're going to check for responsiveness. Do they have a pulse? Are they breathing? And we're going to begin CPR. If they're awake, if they're alert, if they have not began cardiac arrest, but they are having the chest pains and all the signs and symptoms, we want to do our best to calm them. We want to get control of the anxiety. We want to touch that patient to establish a bond, visit with them, explain to them what's going on, let them know about your knowledge. It is super important that you be knowledgeable and educate your patients, because then they trust you. Reassure that patient that you're going to do your very best. And once again, verbalize every step you take. Take the following actions during a heart attack. Move the patient as little as possible. Do not allow them to move themselves. We do not want them to exert anything. We want them to stay completely calm. Place patient in the most comfortable position. Help the patient take one adult aspirin or 2 to 4 low dose aspirin. Administer oxygen. So I'll step back. So the aspirin are 81 milligrams each. They can have 325 milligrams. Usually have them chew them up. They come in different flavors, or you can just make them chew up the nasty ones. Let's see. Administer oxygen as soon as it's available at high flow. Let's have cap now on them. Let's go ahead. We're going to do like a 4 lead when the ambulance gets there. Be prepared to administer CPR if this becomes necessary. If there is an AED available, let's go ahead and get it and have it prepared and ready. Always follow your local protocols administering ASA or aspirin to a patient. So once again, I can't say it enough, follow your local protocols, know what you're doing. Moving on to congestive heart failure, CHF. Congestive heart failure is caused by failure of the heart to pump adequately. So failure in the heart muscle, but congestion is in the blood vessels. So our heart, one part of our heart is unable to pump completely or like normal, and we start to get a buildup of fluids. CHF patients. So the normal exchange of oxygen and carbon dioxide between the capillary and alveoli is affected. Pulmonary edema, congestive heart failure causes fluid to back or to leak from the capillaries and build in alveoli. impending oxygen and carbon dioxide exchange. So we talked about these in our respiratory chapter. I told you how cool they were. Those little balloons that when you take a breath, it goes in, it goes through your bronchioles, through your bronchi, all that gets into the fruit or the leaves. Remember, it gets in them alveoli, and this is where oxygen's getting on board at the bus stop and going to work, and carbon dioxide is getting off and getting out of town. So if you have fluid in there, it is unable to move through that alveoli into those capillary beds and transport like it's supposed to. The ability for it to perfuse across there is limited due to the buildup of fluid. So you do not get near as much oxygen into the bloodstream, and you do not get near the carbon out of the bloodstream. So it's an imbalance. Some of the symptoms, signs that you're going to see is shortness of breath. This is a major symptom. Rapid shallow breathing, moist or gargling respiration, profuse sweating, enlarged neck veins, swollen ankles, and high anxiety. A lot of these you will actually be able to hear with your ears audibly, if you will. That wet Rice Krispie popping, it's a weird sound. Or you can use your stethoscope if you have one, and you can listen to those sounds. In the lower lobes, you're going to hear it probably more so than the upper lobes. Let's see, swollen ankles. Next time you're at Walmart, just look at people's legs. You'll be able to tell who has CHF. They've got them big, puffy, swollen ankles. I don't want to get into detail right now, like large neck veins. We can talk about that later. Profuse sweating. Yeah, it's a good sign. Yes and no, depends on the situation. So the actions that need taken is place the patient in a sitting position with the legs down. This allows fluid to drain to the lower parts of the body and get out of the lungs and heart. The things we're going to do on the truck, I'm not going to talk about, but we can actually help get some of that fluid dispersed out of them lungs. Administer oxygen at a high flow. Summon for additional help. So by now, 911 should have been called. We should be on the way. And communicate once again with us or 911 so that we know when we get there we have a high priority patient that we can get out of there quickly. Dyspnea is shortness of breath or difficulty breathing, usually associated with serious heart or lung disease. Heart-related causes is angina pectoris, heart attack, CHF. Other causes is pulmonary disease such as COPD, emphysema, chronic bronchitis, pneumonia, and asthma. With all of that being said, I don't want you guys to spend a ton of time like learning each one. I want you to learn the very basics. For EMR, all you gotta know is roughly what each one is. So, sorry, I'm trying to look at my notes here. So CHF and emphysema are caused by damage to the air sacs, the alveoli in the lungs, okay? Go ahead and write this stuff down. Just COPD and emphysema is damage to the alveoli. Chronic bronchitis is inflammation of the airways in the lungs. Pneumonia is an infection in the lungs. Asthma is caused by clamping down or spasms of the small airway passages. Just wording it like that is all you need. You don't have to go overboard on learning 2 paragraphs of what each one is means and what causes it and how to notice it. You just need to know the basics. General treatment. So we want to check that patient's airway to be sure that it's not obstructed. Check rate and depth of breathing. I've preached that and preached that. Place patient in a comfortable position, provide reassurance, loosen any tight clothing. We want to make sure that they have absolutely nothing holding in their ability to get good chest rise and fall. Nothing is affecting around their throat, any of their airway. We want everything open and accessible. Administer oxygen if it is available. Asthma, So it's excess mucus production and swelling of the lining of the respiratory passage. It can be caused by an allergic reaction, severe emotional stress, exercise, respiratory infections. Asthma, we can treat. Most people have, if they know they have asthma, they have a meter dosed inhaler or a butyral inhaler. The one thing I'm going to throw out there to you is if you come up on an asthma patient and they're sitting there hitting that inhaler every 30 seconds because it's not working, albuterol will actually elevate your pulse rate. So kind of expect anywhere from a 10 to 20 to 30 beats per minute faster than normal if they're sitting there nailing that inhaler more than they should. Asthma attacks do kill 3,564 people in the United States as of 2017. Patients will have great difficulty in inhaling and exhaling, and wheezing sounds will be heard. So when they exhale, you're going to get that whistle or that screech sound. Follow treatment steps. Instruct patient to perform pulse lips breathing. What that does, sorry, once again, trying to find my notes. So it relieves some of the internal lung pressure that cause asthma attacks. I tried to write notes on here to make it a little bit quicker and easier, but stroke, leading cause of brain injury and disability in adults. According to the CDC, approximately 795,000 adults in the United States have a stroke yearly. There were 1,406,383 strokes deaths in 2017. Most strokes are caused by blood clots. Let's see. Signs and symptoms: headache, numbness or paralysis to one side of the body, dizziness, and confusion. Some of the things we're going to look for stroke are drooling, inability to speak, like me most of the time, difficulty seeing, unequal pupil sizes, unconsciousness, seizures, respiratory arrest, incontinence, and unresponsiveness. We can perform a Cincinnati pre-hospital stroke scale. You need no tools for this. It's used to determine whether a patient's having or experienced a stroke, requires no special equipment, 72% probability of stroke if one of three elements are found. So, see if I can adjust my camera to where you can see me here. So what we want to do is one, face. Have them smile at you. If they can smile normal, they're fine. If they try to smile and one side goes up, one side goes down, possible stroke. Arm drift. So what we're going to do is have them stick their arms straight out, turn your hands upward, and close your eyes. If you get what's called arm drift, one will either fall or it will just slowly kind of drift down. We've got a strike two. That's possible stroke. And then the other one is abnormal speech. Talk to them. Have them repeat a sentence back to you. If there is a lot of slurring or they're unable to pronounce certain words that they normally can, where they just ramble and make no sense, we've got strike three. So if one of any of these hits as a positive, it's a stroke. We need to treat it as a stroke. We need to know when their last normal was. When were they last seen normally? And you definitely need to be on the phone with us or with 911 saying, hey, I did a stroke scale. They are positive in two areas. This is what they're positive in, because we're going to go ahead and call the hospital and we're going to report code stroke. And what this allows that stroke team to be on the floor waiting on us. When we roll up in the ambulance, they have a stroke team ready. We're going to CT. They're getting the TPA ready. If it's a clot, they can give medication that will break that clot up. There's procedures where they can go in and remove the clot, or we can get them to a higher level of care quicker. if you live out in the middle of nowhere like I do. Um, so we want to keep that airway open. Sometimes we're going to have to breathe for them. If a patient's having a seizure, try to prevent further injury and be prepared to administer rescue breathing. Place an unconscious patient in the recovery position, provide emotional support by talking to and touching the patient. Some patients can be treated with drugs. We kind of talked about that. Arrange for prompt transport to a stroke center. So you don't necessarily have to know this. I'm going to tell you this because it's just good knowledge. So if the right side of their body's affected, if they're droopy on the right side, or they have, arm drift on the right side, it's a left-sided stroke. Just like I just said, though, if it's left-sided that's affected, you have a right-sided brain stroke. So what happens in the right affects the left. What happens in the left affects the right. Diabetes caused by the body's inability to process and use glucose. The body produces insulin, which enables glucose to move into individual cells. If the body does not produce enough insulin, cells become starved for glucose, and diabetes results. Glucose is our fuel. It's what our body burns in the cells so that we can keep going. Once again, I don't want to go into a lot of detail, but we use glucose as our fuel. It's just like filling up your vehicle. It's what we burn to keep us moving. It's what our tissues and muscles and everything use to have motion. So hypoglycemia, it occurs if a patient has enough insulin but not enough blood glucose. Signs and symptoms are pale, moist skin, rapid and weak pulse, dizziness or headache, confusion, unconsciousness, sweating. Pale, moist, cool skin, that is a sign of shock. We're going into a diabetic shock. That rapid and weak pulse. So most of the strokes that I've seen, or diabetes, sorry, I'm backtracking for some reason. Any of the diabetic things I've seen, almost every single one of them, the biggest sign I get is this one right here. The confusion and the unconsciousness, that is a huge one. They can be just not there. They're sleeping, they won't wake up, or they're really confused, or they just stare at you and there's nobody home. Those are the things that really throw it out there at me. That's why it's extremely crucial that we get that blood glucose when we do our vitals. Hypoglycemia, signs and symptoms: hunger, rapid onset of symptoms within minutes. Person can be perfectly normal 1 minute, you walk out there and you come back and they're a completely different person. A person experiences hypoglycemia may appear to be drunk. If a patient is unable to swallow, have him or her, if the patient is able to swallow, have him or her eat or drink something sweet, orange juice. I don't like hard candies because they can choke people, but hard candy works. If they cannot, before you give it to them, you need to ask them, swallow for me. See if they can answer a couple questions appropriately. Then you can give them some oral. If they cannot follow those instructions or answer appropriately, we probably don't need to be putting something in their mouth because now we're causing a choking hazard. If trained and authorized by medical control, oral glucose may be used. It's just a gel that we use. We squirt a little bit at a time. If they can swallow, they swallow it. It shoots that glucose up. This is a Band-Aid, though. It's not a fix. The EMTs and paramedics will use glucometer to accurately measure the blood sugar levels. Yes, one of the first things we do is we get a blood sugar. Because it can mimic multiple things. So it's super important we rule that out quick. Hypoglycemia, if the patient is unconscious, open the airway and assist breathing and circulation. Do not administer fluids by mouth. Can't repeat that enough. Some EMRs carry a tube of oral glucose gel or tablets that can be placed inside the cheek, not if they are unable to follow commands. If they can follow commands, that's fine. That's great. Awesome. Once we get that blood sugar up, it's important that they eat something. Cheese and crackers, peanut butter sandwich, peanut butter and jelly sandwich. We need to get something in them to maintain that level of sugar in their body. Sorry, I had a brain fart. Diabetic coma occurs when the body has too much blood glucose and not enough insulin. Signs and symptoms, history of diabetes. They will be warm, dry skin, rapid pulse, deep, rapid breathing, fruity odor on the patient's breath. A lot of us have heard about that. And it's because of the high amount of sugar in their body that is not being used. That's why we get that sweet smell. Diabetic coma, signs and symptoms: weakness, nausea, vomiting, increased hunger, thirst, or urination, slow onset of symptoms. Misdiagnosis is common. It is not always easy to diagnose between hypoglycemia and diabetic coma. So remember, hypo means low. Hyper means high. So we have a low blood sugar, or we have diabetic coma. It's hard to tell. That's why we need to go ahead and get that blood glucose tested using our glucometer. So if you want, you can go ahead and take a picture of this with your phone, write it in your notebook, whatever. You kind of need to know these. I promise you, if you're in class, we're going to use some of these as some of your skills tests or scenarios. Diabetes again, diabetic coma in general. Give conscious diabetic patients sugar by mouth and arrange for a prompt transport. This is a high priority patient. If diabetic patient is unconscious, arrange for prompt transport. If we show up, you haven't administered anything, what we're going to do, we're going to check that blood sugar. If it's low, we're going to start a line. And in my service that I work for, we're going to push D10. We're going to hang a bag of D10 and we're going to titrate that until we get their sugar up. We're going to transport them to the hospital and try to keep that maintained. Before I move on, once we start treating this patient, whether you are an EMR that happened to be there and you gave them a hard candy or you had them drink orange juice, whatever, we need to stay with this patient and we reassess that blood sugar every 3 to 5 minutes. Constantly, we're rechecking it every 3 to 5. Abdominal pains. So there's a whole lot that goes into this. Contents of the abdomen are divided into hollow and solid structures. Hollow structures are really tubes through which content passes. Solid structures produce substance. If you can remember them two things, it will help you. Abdominal pain is a common complaint. Acute abdomen caused by irritation of the abdominal wall may result from infection or the presence of blood in the abdominal cavity. Pain can be referred to other parts of the body. Abdomen may feel hard as a board when you palpate it, when we touch it. Patients may have nausea, vomiting, fever, and diarrhea as well as pain. So when we start doing our hands-on assessment, you will push all 4 quadrants, which we'll learn about. And if you get hardness, rigidity, tenderness, any of that, then we need to be paying attention to what might be causing that. Some patients will vomit blood because they are bleeding from the esophagus or stomach. If a patient has abdominal pain, we need to monitor those vital signs. As soon as we're done assessing, we reassess, right? Treat symptoms of shock, which the way we treat that, and I know we haven't done shock yet, is we're going to lay them down if possible, unless they're vomiting. We want to give them high flow oxygen and we want to put a blanket over them to maintain body heat. Keep the patient comfortable as possible and arrange for a transport. So abdominal aortic aneurysm, this is called a AAA. One cause of acute abdomen occurs when one or more layers of the aorta become weakened and it separates from other layers of the aorta. It's extremely painful. Risk factors is diabetes, high blood pressure, thickening of the arteries, and heavy smoking. Patients, if a AAA ruptures, patient will experience severe pain and profound shock. So if it ruptures, we are actually bleeding out on the inside. So they will go into shock very, very quickly. Treating a AAA, place patient in a comfortable position, treat patient for shock, like I told you a moment ago, handle these patients gently, and arrange for extremely prompt transport. Kidney dialysis patients, we do run into this. In my part of the country, we do a lot of dialysis transports. So people with certain types of kidney diseases are unable to filter waste products from their bloodstream. So dialysis does that for them. Many patients with chronic renal failure must undergo hemodialysis, which is hemo means blood, okay? Patient's blood passes through a machine that filters out waste product and returns cleaned blood to the patient. So that is what dialysis is. It cleans the blood in a machine because your body is unable to do it. These patients are very prone to sepsis. Hemodialysis, most hemodialysis patients have a shunt implanted in their arm or leg. A shunt is a surgically created connector between the arteries and veins. The patient has a shunt. Take the patient's BP in the arm without the shunt. So if you go on a patient and the history says they are a dialysis patient, or I have dialysis tomorrow, or I just went to dialysis, ask them, where can I take your blood pressure? They will be able to tell you where their port is, and you can go from there. Patients may experience emergencies related to their dialysis treatment. So low blood pressure due to changes in their body, shock due to decreased blood pressures, internal bleeding, abnormal levels of electrolytes, which can cause cardiac dysrhythmias. Infectious diseases and epidemics. You must understand a few principles about infectious disease so you can protect yourself, provide proper patient care, and help to prevent the spread of infectious diseases to other people. Infectious diseases can be spread from person to person by direct contact, indirect contact, or contact with blood. That's in chapter 2. Katie's going to go over that. And then I have posted chapter 2's video if you want to come watch it and run through it. An epidemic is an infectious disease or condition that affects many people at the same time in the same geographic area. So that epidemic is in the same area. If an epidemic spreads to many different parts of the world at the same time, it is called a pandemic. We all remember COVID-19 pandemic. That's because it covered a large area. It wasn't just isolated. Review the examples of epidemic and pandemics since the year 2000 on table 10.3 in your book. So epidemics and pandemics that have occurred since 2000s, we had the SARS pandemic, Ebola epidemic, swine flu pandemic, the MERS pandemic, and then COVID-19 pandemic. And you can see over here on locations, it was China, Hong Kong, Taiwan, Canada, Singapore. You can see that. And then the last 3 were worldwide. So your summary, guys, everything we've talked about, I don't need to read all this to you. What I'm going to tell you, read your chapter. Like I said, don't dig in too deep. Don't overdo it. Learn the basics right now. If you go on to EMT, Advanced EMT Paramedic, we get more into depth as it goes for a reason. Keep it simple. Remember, assessment is key. We really, really need to pay attention to our assessment. When I say assessment, that starts with is the scene safe and do we have our gloves on, all the way down to end of the call. When either you turn it over to EMS when we arrive, or if you're on a truck when we arrive at the emergency department and we've turned that patient over to the hospital. You're going to get these assessment sheets. It's going to make more sense than just sitting here and listening to me rattle. I cannot stress enough about let's get our vitals, let's redo our assessments, let's check that AFU, because those are key, especially at the EMR EMT level. It tells us a ton, and you will learn it as time goes by. So don't beat yourself up yet. I know this is still all confusing. Let's see. It's important that we do understand the signs and symptoms of our cardiac events, of our strokes, of our blood sugar, or our mine went blank again. Diabetic emergencies, that's what I was trying to say. We do need to learn the signs and symptoms, and we will. The more we work together, the easier it will become. So real quick, let's run through this. Signs and symptoms of a stroke include all of the following except. I'm going to tell you guys right now as we start doing quizzes and tests. Read these questions and look for that word right there. It'll get you. And that's through your entire EMS career. We need to pay attention to that. So signs and symptoms of a stroke, is there numbness and paralysis? Yeah. Is there high fever? Maybe. Is there drooling? If they lose function of one side of their face, could they actually be drooling? Definitely. How about unequal pupil sizes? So once again, we are losing muscular control. We're losing involuntary muscle control. So I'm going to say B. High fever is not going to come with stroke. High fever is going to come with your infections or your colds, your flus, that kind of stuff. So high fever is not something to look for in strokes. Which of the following actions would not be appropriate when managing a patient who is suffering from a heart attack? So what is something that is not appropriate when dealing with a heart attack? Placing the patient in the most comfortable position, administering oxygen, being prepared to do CPR, or moving the patient quickly as possible to the ambulance. So we want them comfortable, right? We don't want them straining. We don't want them uncomfortable. We want to give oxygen because there's something not feeding well enough. We're not getting enough oxygen. So let's give them some O's. If we're at that point that we're scared about a heart attack, yeah, let's go ahead and be prepared mentally to do CPR. I'm going to say that D, we don't need to move quickly as possible to the ambulance for transport. We need to work our patient, do our assessment, do our vitals, right? Here we go. And then hypoglycemia occurs when a patient, so let's look at that word, hypoglycemia, that is low, right? Consumes too many high-fat foods, has enough insulin, not enough blood glucose, suffers from dehydration, has too much blood glucose and not enough insulin. Which one was it? Hypoglycemia is, yep, has enough insulin, but not enough glucose. Hypoglycemia is low sugar. There you go. Guys, thank you for sticking it out with me. I know that it was a long one. These are important things. Please, please, please send me messages or text me or get on YouTube and send me a message if there's something in particular we need to go more in depth with for you to understand this stuff. I'm here so you can pass this class and understand it. So reach out to me. That's all I got this time, guys. I'll see you on chapter 11.